So kita orang akan present for pediatric case study which is bronchial asthma. This group member is Nur Izzah binti Kamrul Zaman, myself Norizati Khadijah binti Sabturo, and Nur Halimatul Saadia binti Ramli. So this is the content outline, which is demographic data, patient history, causes of admission, signs and symptoms, physical examination, definition, pathophysiology, asthma triggers, investigation, treatment, growth and development, nursing process, health education, and reference. So first for the demographic data, this patient name is Muhammad Zahrin bin Muhammad Sazrul Fitri, registered number N807930. Birth date is 26 of August 2020 and born at 41 weeks with birth weight 2.56 kilogram. So this patient is from Wat Perubatan Medical, bed number 26, and this patient is male with race Malay and religion Islam. So his next of kin is Siti Shohada binti Jaafar, which is his mother, with telephone number 016-850-4755, and date of admission is 22 of May 2020. Next is patient history, which is the prenatal care. So this patient is the second child, which is Paratu for his mother. The maternal history is her first child born on 2015 and her second child born on 2020, which is the patient, and both children born through spontaneous vaginal delivery. And on infective screening, blood test for 3 infectious diseases for this patient, which is the second child. Hepatitis B, HIV, and syphilis are all normal. And for the labor and delivery history, type of delivery is spontaneous vaginal delivery. Type of anesthesia, epidural, and expected date of delivery is 1 week before EDD, which is 3 or 3rd of September 2022. And ABGAS code during the birth is 9/10. Next is medical and surgical history. 2 weeks prior to admission, this patient had hand, foot, and mouth disease, and patient had not undergone any surgery so far. And for the immunization history, this patient had BCG injection on 26 of August 2020, having hepatitis B injection on 26 of August 2020, on 1st of September 2020, and on 1st of February of 2021. Patient having DPT injection on 1st of October 2020 and MMR injection on 1st of May 2021. And for the social history, patient is living with a nucleus family including father, mother, and her sister. Next is family history. His grandfather having no medical illness, but her grandmother have an asthma. Her father, his father having no medical illness, which is 39 years old, a male. His mother having asthma, which is 34 years old, Malay woman. His sister having no medical illness, which is 7 years old. And this patient is newly diagnosed with asthma, this patient is 1 year old currently. So the family has a strong family history of asthma, which is from his grandmother and from his mother. Then other than that, the family have no other medical illness. So the cause of admission is patient came to the emergency department with chief complaints of rapid breathing for 1 day with an audible wheeze. So basically, initially, this rapid breathing started on Wednesday, which is 18 of May 2022, which mother noted rapid breathing, then brought to general practitioner and was given nebulizer. Patient then discharged home with oral antibiotic, antipyretic, runny nose medication, and subsequently resolved. Then patient was discharged for home. Then, however, on 22 of May 2022, which is the date of admission, mother noted patient having rapid breathing with an audible wheeze sound since 4 p.m. Then mother brought patient to Clinic City, but the Clinic City found out that patient having bronchi hurt on lungs. Then patient was referred to HUKM. So for the current health status, problems and signs and symptoms, patient still having rapid breathing with sounds. Patient also having chesty, dry and non-productive cough for 2 days associated with post-tussive vomiting one time. Patient having runny noses for 2 weeks with clear nasal discharge. Having poor oral intake for 1 day which took less solid food than usual. Then patient had fever for 2 days starting on 15th of May 2022 and documented temperature at home is less than 38. Mother gave syrup PCM and subsequently resolved and currently febrile. So patient current health status only resolved for the febrile. So for the physical examination, which is head to toe, for the anthropometric measurements, patient weight is 11 kilogram currently, length 75 centimeter, and head circumference is 40 centimeter. For the vital signs during the interview, which is temperature 36.5 degrees Celsius, heart rate 127 a beat per minute, respiration rate 30 breath per minute, and blood pressure is 90/70. For the integumentary, which is the skin, first assessment is skin. Skin is in normal appearance, feels warm and no other abnormalities. Hair is in normal and no abnormalities since. No spoon or clubbing finger, no cyanosis, capillary refill less than 2 seconds. For the head, symmetry is no lesion. For the head, it is symmetry, no lesion and no discharge. Anterior and posterior fontanelle already closed. For the neck is aligned symmetry and no crepitus. Eyes align symmetrically, no redness. Pupils are equal and react to light. For the ears, nose, mouth, and throat, ears align symmetrically, respond to sound, both sides of nose symmetrical. Nose is in the middle of the face and had runny nose 2 weeks. Lips are moist and pink. So for the chest lungs, which is the respiratory part, patient is having chesty cough, breath sounds, rapid breathing since 18th of May 2022 associated with rhonchi and wheezing sounds. But currently, patient still having rapid breathing with wheezing sound. For the cardiovascular system, patient is having dual rhythm and no murmur. For the abdomen, patient is having soft and protruded abdomen with normal bowel sounds. Genitalia and rectum, patient is male gender. No source or lesions, no swelling or discharge, testis descent, and genitalia covered with foreskin. For the back and extremities, which is the musculoskeletal, patient posture is symmetry, have curvature of spine. Spine is rounded and flexible. Gait and posture are normal. And for the neurological and reflexes, patient glaucoma scale is 15/15. So this patient had been diagnosed with medical diagnosis of acute exacerbation of bronchial asthma.
Next, kita masuk pada disease for asthma. Asthma is a common chronic disorder of the airways that is complex and characterized by variable recurring symptoms such as airflow obstruction, bronchial hyperresponsiveness, and underlying inflammation. Okay, dalam gambar ni kita boleh tengok beza patient yang normal dengan yang ada asthmatic airway, yang inflame and thicken mucus dalam smooth muscle ni lah. Okay, next. Untuk pathophysiology of asthma, okay, first, ini dalam kategori allergen triggered lah, allergen triggered reaction. Contoh macam dust ke hair ke kan. So first allergen engulf. Bila engulf with the skin, by activation dia akan engulf with the skin by activation of dendritic cell. So bila dah activated dendritic cell ni, columnar epithelial cell akan recognize thymic stromal lymphopoietin untuk activate lagi DC ni untuk attract T helper cells. So bila T helper cells ni dah activate, dia akan activate lagi untuk differentiate T helper cell 1 dan T helper cell 2. So at the same time, dendritic cell ni juga dia akan produce chemokines. So bila chemokines ni akan attract specifically kepada T helper cell ni. Okay, untuk patient asthma, dia T helper cell ni adalah normal physiology untuk human body lah untuk produce immunity. Tapi untuk asthmatic patient, T helper cell 1 dan T helper cell 2 ini adalah imbalance, which is asthma patient akan ada T helper cell 2 ni more production daripada normal. So bila dia more production akan berlaku imbalance lah. Apabila TH2 normal ni lebih, dia akan stimulate plasma untuk promote IgE production, which is for allergic reaction. And then IgE akan bind kepada muscles, which is dekat lung muscle lah, smooth muscle lung. And then dia akan stimulate lagi promote of mast cell production. And then dia akan promote juga eosinophil production from bone marrow. So dia akan trigger immune system yang ada dekat lung tu. So itu bezanya asthmatic patient dengan patient normal. T helper cells 2 ni yang akan trigger more reaction. And then bila eosinophil production ni tinggi, dia akan attract kepada lungs. And bila allergen tu dah inhale by lung, dia akan bind kepada IgE muscle complex. So bila dah bind, dia akan stimulate smooth muscle in airways dan akan berlakulah bronchoconstriction. So for bila release-nya histamine, prostaglandin dan leukotrienes ni, most probably histamine ni lah yang akan menyebabkan bronchoconstriction dalam airway untuk asthmatic patient. Okay, next. Kita tengok gambar dia. Kalau nak lebih faham, ini adalah gambar diagram dia lah. Bagaimana T4, T2 dengan helper T cell yang 1 and 2 ni unbalanced, and then bila allergenic bind kepada IgE seperti yang saya cakap tadi. And belah kanan ni just summarize untuk mudahkan faham lah macam mana daripada trigger factor tu boleh menyebabkan hypersecretion, airway muscle contraction, swelling, lepas tu akan menyebabkan narrow breathing passage. Lastly, akan bila dah worsen akan menyebabkan wheezing, short of breath, tightening in chest. Itu dari segi patofisiologi dia lah. Okay, tadi yang saya sebut triggers tu, ini adalah common asthma triggers lah, especially for pediatric case lah. Allergens ni yang paling common lah, inhale pollen ataupun dust, and then whether sama ada cold air or wine ataupun rain ataupun sudden weather changes. And then tobacco smoke ni more kepada spesies smoker lah, sama ada ayah atau ibu dia yang merokok. Tapi untuk patient ni ayah dia tak merokok lah, more kepada genetic factor which is strong history of asthma untuk patient ni lah. And then ada possible triggers adalah air pollutants, sama ada dia paint fumes ke, asap kereta ke apa ke. And then general lah, ni more to general, exercise, hyperventilation ke, and then respiratory tract infection, sama ada flu atau common cold. But related to patient, more to genetical factor lah.
Okay, saya akan teruskan dengan investigation for asthma. Kita akan investigate melalui 4 cara, iaitu first adalah spirometry. Spirometry ni dia adalah device untuk kita check lung punya kekuatan lung tu lah. So yang kedua adalah peak flow meter. Yang ketiga adalah radiologi, contohnya macam chest x-ray. Lepas tu yang keempat adalah allergic skin test, untuk tahu sama ada dia allergic atau tak. Seperti yang kawan saya cakap tadi, allergic tu adalah salah satu trigger dia. So untuk patient ni just buat chest x-ray tu under radiology. Okay, next.
Okay, untuk treatment ni memang related to patient lah. Treatment yang patient dapat more to ialah asthma medication, inhaler lah. Untuk dia punya inhaler, dia ada doktor order budesonide 200 UG, 1 puff 2 times daily. Okay, budesonide ni adalah corticosteroid which is anti-inflammatory, atau nama lain dia preventer inhaler. So untuk budesonide ni dia kena ambil setiap hari sampailah, tak kira lah tak ada asthma attack pun dia kena ambil. To prevent symptoms of attack tu, asthma attack tu datang. Okay. Antara side effect dia lah ada headache, runny nose, or sore throat lah. And then another inhaler yang sangat common untuk asthmatic patients, salbutamol, Dr. 100 mg, Ventolin. And then kalau yang salbutamol ni 4 puff 4 hourly. Ini during asthmatic attack lah, ataupun ini adalah bronchodilator in short acting lah. Untuk nama lain dia macam rescue inhaler untuk melegakan, relief the asthmatic attack. And then another side effect of salbutamol adalah trembling, headache, palpitation of muscle ataupun muscle cramp lah. And another medications yang help treat preventing the symptom prednisolone lah. Doctor order 10 mg once daily. Dia adalah another type of corticosteroid which is anti-inflammatory. And then same dia punya side effect lebih kurang nausea, headache and dizziness. Ni 3 ubat yang untuk treat asma main lah. And other medications yang di-prescribe kepada patient ni adalah PCN suspension, 165 mg QID, ini adalah analgesic atau antipyretic. Antara side effect dia adalah nausea, vomiting, skin rash ataupun allergic lah, which is sangat rare lah. And then dia ada juga sirap simplex. Sirap simplex ni adalah satu solution of sucrose or sugar yang ditambah ataupun tidak ditambah medical substance in purified water, sebab mostly in pediatric, sebab kebanyakan ubat yang mereka dapatkan adalah pahit kan, tapi sirap simplex ni untuk top up substitute rasa tawar tu kepada budak-budak, sebab budak-budak kalau kan tak suka tawar, ubat yang tawar. Jadi sirap simplex ni one of another pharmacological treatment lah untuk bagi budak tu makan ubat. So common lah sirap simplex ni untuk pediatric patient. And then cefuroxime acetyl, antibiotik lah, cephalosporin, side effect dia nausea, vomiting ataupun headache.
Okay, seterusnya adalah growth and development untuk untuk patient ni. Okay, ini berdasarkan child development milestone untuk 1 tahun hingga 2 tahun. Untuk physical, patient tu can walk, climb and run. Lepas tu dia boleh climb into the chair, boleh kick and throw a ball, feed themselves, begin to run, turn page of book 2 or 3 pages at a time, finger feed efficiently, squats to pick up an object, can drink from a cup, and tries to use spoon and fork. Untuk emotional dia, they can show anxiety when separating from significant people in their life, seek comfort when upset or afraid. Sebab dia kan dah kenal orang, so dia akan ada anxiety. Okay, untuk cognitive, dia boleh point to object when named, know somebody body parts, and recognize self in a photo or mirror, may signal when she or he finish their toileting, spend a lot time exploring and manipulating object, putting in mouth, shaking and begging them, persist, stack and knocks over the time, and calls meaningful sentence like mama, papa, kakak, nak atau tak. Okay. Next.
Okay, for the nursing diagnosis, first nursing diagnosis is ineffective airway clearance related to ineffective cough as evidenced by shortness of breath, wheeze and chesty cough. So patient will maintain airway patency as evidenced by clear breath sounds, depth of respiration and ability to effectively cough out secretions. So for the intervention is first assess patient's vital sign and characteristics of respirations at least every 4 hours to assist in creating an accurate diagnosis and monitor effectiveness of medical treatment. Then we will assess breath sounds via auscultation because wheeze is one of the important signs of asthma. Then we will encourage coughing and suction secretions as needed to help clear thick phlegm that the patient is unable to expectorate. Then we will administer supplemental oxygen as prescribed and discontinue as ordered by the physician to increase the oxygen level oxygen level and achieve an SpO2 value within the target range. Then we will administer prescribed asthma medications such as bronchodilators, steroids or combination inhalers or nebulizer to dilate or relax the muscles on the airways and to reduce the inflammation in the lungs. Then we will elevate head of the bed to semi-follows position to improve the expansions of the lungs, enabling the patient to breathe more effectively. Then lastly, we will collaborate with physiotherapy for suctioning and chest percussion to mobilize the secretion from the small airway. So for the evaluation, patient will get to maintain airway patency as evidenced by clear breath sounds, depth of respiration, and ability to effectively cough out secretions. For the second nursing diagnosis, it is impaired breathing pattern related to inadequate pulmonary ventilation. Secondary to asthma is evidenced by shortness of breath, coughing, and rapid breathing pattern. So for the outcome, the patient's abnormal breathing pattern will be corrected as evidenced by a normal respiratory pattern with no evidence of dyspnea noted. So for the first intervention is, we will monitor patient vital signs readings while he is in a state of distress because increased blood pressure, respiration rate, and heart rate occur during the initial hypoxia and hypercapnia. Then we will monitor oxygen saturation with normal oxygen saturation levels, which is we considered 95 to 100% to make sure patient get enough oxygen needed. Then we will monitor at arterial blood gases, which is the ABG, to serve as baseline and provide information where the patient is at risk of having or developing respiratory alkalosis or respiratory acidosis. Then we will suggest patient to inhale and exhale via pursed lips to allow more fresh air to enter the lungs while expelling old air he has been holding in. Then we will positioning patient to semi-Fowler's position to facilitate the patient's breathing and maximal lung expansion. Then lastly, we will encourage calm and deep breathing exercise to improve patient breathing pattern. So for the evaluation, the patient will having normal breathing pattern with normal respiratory pattern and no dyspnea noted.
The next is diagnosis adalah imbalanced nutrition related to loss of appetite as manifested by patient having weight loss. So the outcome is patient will be able to achieve weight within his normal BMI range by demonstrating a healthy eating pattern after 2 days of hospitalization. Then the intervention, firstly, assess patient's nutritional status daily to provide more information regarding his regular diet. Then monitor input and output chart per shift to note for any food or oral deficit. And then monitor patients' weight daily to effectively note progress in weight goals. And then encourage family to educate the child on importance of healthy diet and involve in the management to increase the weight. And then refer dietitian to provide more specialized care for patient nutrition. And then the evaluation is patient is able to achieve weight within his normal BMI range by demonstrating a healthy eating pattern after 2 days of hospitalization. Okay, next. Okay, yang keempat, activity intolerance related to generalized weakness as manifested by patient having airway problem. And then outcome, patient will be able to demonstrate active participation in necessary activities by showing interest and demonstrate increase in activity level after 3 days of hospitalization. Firstly, for the intervention, assess the physical activity level and mobility of the patient to provide baseline information for further management. And then assess the need for ambulation aid, such as can or walking to assist in activity daily living. And then monitor vital signs for hourly to note for any abnormalities, and then educate family and child about the deep breathing exercise to maximize efficient breathing. And then encourage mother and child to do active range of motion exercise to maintain muscle strength. And then lastly, refers physiotherapist for specific ambulation aids to prevent from muscle stiffness. And then the evaluation, patient is able to demonstrate active participation in necessary activities by showing interest and demonstrate increase in activity level after 3 days of hospitalization.
Okay, next adalah risk of loss of weight related to poor oral intake. Outcome dia adalah patient will gain weight within 1 week. Intervention first adalah assess patient intake and output chart to know patient nutritional status. Second, assess patient eating pattern to determine nutritional risk and worsening nutritional status. Third, weight patient daily to serve as baseline data and provide information about dietary needs. Fourth, encourage the caregiver to do oral care hygiene in order to help the patient to increase his appetite and enhance the taste of food. Fifth, encourage the caregiver to bring his favorite food to increase his appetite and promote weight gain. Then educate caregiver to give him a healthy diet like high calorie, nutrient rich diet and adequate fluid intake to increase metabolic process. And last, collaborate with a dietitian to plan a suitable diet for a patient to increase his weight. The evaluation, patient gain weight within 1 week. Okay, next. Risk for volume deficit related to decreased intake of fluid. Okay, patient will not experience dehydration during the hospitalization. First intervention, assess patient's skin turgor and oral mucous membrane for sign of dehydration to know the patient's current condition. Second, monitor and record the vital sign, especially blood pressure and heart rate to know the patient progress. Third, monitor intake and output chart to prevent sign of volume deficit and plan for the future care. And fourth, encourage the caregiver to give patient more fluid to avoid the dehydration. And fifth, educate the caregiver about the sign and symptom of dehydration to increase the awareness and reduce level of anxiety. And last is emphasize the caregiver the importance of oral hygiene to promote interest in drinking and reduce discomfort of dry mucous membrane. Okay, for the evaluation is patient not experience the dehydration during the hospitalization.
Okay, lastly, for the health education, first of all, we will emphasize the caregiver about the importance and side effects of taking medication that is prescribed by the doctor to avoid complication. Then we will educate patient about the importance to follow the appointment after discharge to know patient progress. Then we will educate caregivers about hygiene, especially hand hygiene, like hand washing before and after doing activity to promote a healthy lifestyle. Then we will encourage caregivers to give a healthy diet to the patient that does not trigger her disease, which is asthma, like more vegetable and fruits, low carbohydrate, grains, and less sugar. And then lastly, we will educate caregivers about the correct way to use MDI, which is the method dose inhaler, with an aero chamber to increase the effectiveness of medication. So this is our reference. And that's all from our group. Thank you.